Hi, I'm Dr. Stephen Hamilton. I'm a cardiac electrophysiologist in El Paso, Texas. And I was asked to discuss atrial fibrillation, which is one of the most common conditions that I treat in my practice. So welcome to the talk. I'm going to be giving some patient information about atrial fibrillation and hopefully answer some of the more common questions that people ask me when they see me in clinic. This is my name. My specialty in medicine is cardiac electrophysiology. People think of me as an electrician for the heart. My specialty deals with heart rhythm problems, and we do that both medically and procedurally. So what is atrial fibrillation? Atrial fibrillation, or AFib, is the most common type of cardiac arrhythmia. It occurs when the upper chambers of the heart, called the atria, beat very fast and very irregular. There's about 5.5 million people that have the condition but have not been diagnosed. And it happens about 1/4 of people over 40 years old. Sometimes you may see it referred to as AFib or AF. So there's a few different types of atrial fibrillation. When people first get AFib, a lot of times they spend a little bit of time in it and then they switch back to their normal rhythm. Over time, it becomes progressively longer, the episodes, until people transition to being in AFib all of the time. So this slide is just showing what we call some of those steps, going from the first episode of AFib to what we call long-standing persistent AFib, where people are in AFib continuously. So there are quite a few things that have been described as risk factors for AFib. There are quite a few. Really, the strongest risk factors are things that you can't control. Those are things like age, family history, and history of heart disease. There are some things that we can control. These have different levels of effect on controlling AFib. One of the things that's under-recognized, in my opinion, is sleep apnea. People that have sleep apnea, snore a lot, disorders with sleeping, they're at much higher risk for AFib, and any treatment that we do for AFib is better if people have these things under control. Weight loss, alcohol, smoking, caffeine, all of these are important for overall health, including cardiovascular health and helping to control atrial fibrillation. So atrial fibrillation, like most things in medicine, is a team approach. A lot of times the first diagnosis happens with a primary care physician. A lot of times people end up getting referred to a cardiologist, or maybe they end up in the hospital and a cardiologist is the first one to diagnose and manage. AFib, we saw stress as a factor for AFib. So periods of high stress, like after a major surgery, a lot of times that's the first time people find out that they have atrial fibrillation. Electrophysiology is a special type of cardiologist. We work together with cardiologists to help manage atrial fibrillation. That's where I come in. So there are any number of ways that people can have AFib picked up at first. These are some of them. Really, the standard test is probably an outpatient monitor that you wear. Nowadays, there are several that are available directly to consumers. Some smart watches, there are little devices that you can monitor your heart rhythm electrically, and those have become a very common way for people to detect AFib early on. This slide shows that, the treatment pathway is different for different people. There's a lot of decisions to be made. I won't go into too much detail with this, but there's a lot of different options, and we sort of tailor the treatment approach to whatever's best for patients. So AFib, these are some of the more common symptoms people have related to atrial fibrillation. People don't necessarily have to be symptomatic, and a lot of times the symptoms sort of sneak up on people. It starts out where they're in AFib for short periods of time that gradually get longer, more frequent. So this can be a very slow, progressive symptom decline that people have over months to years. But these are all things that are described to me every day I'm in clinic: fatigue, shortness of breath, anxiety, palpitations or feeling like the heart's beating really fast, weakness, sweating. All of these things are very common symptoms from atrial fibrillation. They're common symptoms of other things too, but AFib, if you're having these symptoms, it's worth checking with your primary care or your cardiologist to investigate that. So whether you have symptoms from AFib or not, everybody with AFib has some stroke risk that is above what the normal population is that does not have AFib. In order to determine that stroke risk, we use data from large studies, and we have these risk scores to decide, what the best way to prevent strokes is for these patients. The overall stroke risk in atrial fibrillation is 5 times what it is for somebody who doesn't have AFib, and about 1/3 of all strokes are caused by atrial fibrillation. There are other things that can cause strokes too besides AFib. There's some data to suggest that strokes from AFib are worse than strokes from other causes. The reason people develop strokes from AFib is when the upper chamber is beating very rapidly in the heart, it doesn't move blood very well. The heart's a pump for blood. So when blood stands still, it can form clots. And if those clots dislodge and they go to the brain, they can block blood flow to the brain and cause a stroke. So there's a few signs of stroke that are probably going to be part of some of the other talks as part of heart and heart week. But these are some of the more common early symptoms. So there's 2 ways that we can prevent strokes. There are blood thinner medicines that people take regularly to thin the blood and prevent blood clots from forming. And then fairly recently, but not brand new, is left atrial appendage closure, which is a procedural option that I'm going to just talk about briefly. So sometimes people can't take blood thinners because bleeding risk is higher when you're on blood thinners. So for those patients, left atrial appendage closure is an option to block this little pouch called the left atrial appendage in the heart. This little pouch has a tendency to form clots when blood's not moving very well. And these devices can occlude that pouch, and then the body heals over the device, and then the stroke risk in somebody who, after they've healed over the device, the stroke risk is the same when they're off blood thinners as somebody who continues to take blood thinners. So this has been an advancement that has really helped a lot of patients. For atrial fibrillation itself, treating the rhythm, not just the stroke risk, there are a few options. These are kind of 3 general categories to divide them in. I'm going to touch on these briefly, but cardioversion, medications, and then catheter ablation. Cardioversion is a shock to the heart. We place large stickers on the chest wall, and then we sedate people, get them real sleepy, and then we shock and electrically reset the heart. This requires people to be on blood thinners to prevent stroke. Depending on what you read, it has a fairly high chance for AFib recurrence. It may be 50-50 within a year, maybe a little bit higher than that, depending on what source you look at. This is more of a temporary solution to get people feeling better and get them out of AFib in the short term, but does not provide a long-term, it's not a long-term control option for people. We often do these in the hospital when people are sick and their AFib is more difficult to control. Medications, we can use these in combination with cardioversion or catheter ablation, which I'm going to talk about next. Medicines, we sort of have 2 options, some medicines to slow the heart rate down, and then another category called antiarrhythmic drugs, that their goal is to alter the electrical conduction in the heart to maintain a normal rhythm. We use these also in combination with blood thinners to prevent risk of stroke. Sometimes I guess overwhelming and troublesome can be true for a lot of different things. Antiarrhythmic medicines, the more powerful medicines also have worse side effects. Depending on which medication is selected, some of the lower side effect medicines have about 10% of people that have things like nausea and dizziness. Some of the really powerful ones have long-term toxicity risks that have to be monitored very closely. The long-term efficacy of medicines, it depends on how long people have had AFib. It can be about 50%, maybe a little bit better than that, depending on the patient. But they're very effective. We can combine them with other treatment options, and they work together with other treatments to help maintain normal rhythm. Sometimes people have been on medicines for a while. Sometimes they last many, many years on medicines. Sometimes it can be a matter of months. But occasionally medicines just don't work for people. There's too many rhythm areas that are causing problems. And even with the most powerful antiarrhythmic medicines, we're not able to control their atrial fibrillation. And those patients who either prefer not to take medicines or not to take quite as strong a medicines, or in patients where medicines fail, we have an option called catheter ablation. This is a procedure that's done through small pokes or incisions in the groin through the vein. And we put catheters that look like spaghetti noodles with electrodes up into the heart. And then with those catheters, we can map the electrical signals and then deliver either heat or cold energy to the heart, to the areas that are causing the electrical problems. There are some risks with the procedure, like any procedure. Bleeding is the most common with the site where we put those small little tubes in the groin. Overall, generally the risk's about 1% for some type of procedural complication like bleeding, and things that are serious is about 1 in 1,000 for some of these other things mentioned here. So catheter ablation again, failing drug therapy, AFib causing symptoms, especially those patients. And then there's some controversial evidence about whether it decreases your risk for stroke. Really the cornerstone of stroke risk reduction remains blood thinners and those atrial appendage closure devices I mentioned. So a lot of times I'll see people in clinic, and these don't tend to be emergency situations when people have AFib first detected in clinic visits. Like I mentioned, it's a progressive condition. And it gets worse over time as people progress from new diagnosis to persistent to longstanding persistent. All of these treatment options have reduced efficacy. So I don't try and pressure patients into making quick decisions or rash decisions, but the things that we can offer people do work much better if we perform them early on in the course of AFib rather than once people have had AFib for several years. And it's important early on to start blood thinners or consider appendage closure to reduce stroke risk. And so I think take the time to talk with your physicians and make a solid decision, but it's not something I would postpone for months at a time. With that, I'd like to thank you for listening, and I hope everyone has a great Heart Week.